Hello everyone, Dr.Jyotsna here. So, how to go for vasopressors in septic shock and when to start steroid in septic shock. We all know noradrenaline as alpha agonist having good vasoconstrictive effect is very useful in and is the first line agent of septic shock as it is a good vasoconstrictor and septic shock being a vasodilatory state, it is a very effective. But so let's know first what is the initial dose. The initial dose of noradrenaline should be started at 0.05 to 1 microgram per kg per minute, and it can be increases up to 0.3 microgram per kg per minute. And even if you are not able to maintain a MAP of greater than equal to 65, you add vasopressor pressin. So vasopressin is added if the noradrenaline is not able to maintain MAP of 65 even with the dose of more than 0.3 microgram per kg per minute. When you will add vasopressin, you have to add at a fixed dose. You don't titrate it. The dose is 0.03 international unit per minute. So it helps in decreasing the noradrenaline dose. It also has a, as it is not a sympathomimetic drugs, it has a sympathetic sparing activities. So the activities like sympathetic activities which we didn't want it with the noradrenaline, which that will not be there with this vasopressin, like limb ischemia, myocardial ischemia, because it's a vasoconstrictor. So all the side effect related to vasoconstriction could not be useful in any way, even in vasodilatory shock. So if the dose increases more than 0.3 microgram per kg per minute, in that case we have to add this vasopressin. Now, despite of adding noradrenaline and vasopressin, then also the patient is not able to maintain MAP of 65, then you add or the patient is having cardiac dysfunction also, so then you can add adrenaline. Adrenaline is added at a dose of same as 0.05 to 1 microgram 0.05 to 0.1 microgram per kg per minute, and you can titrate it up to 1 microgram per kg per minute. So suppose with all these things also, or if with noradrenaline, vasopressin also, and you have to start now adrenaline, so all these things had been started, then this is, so it is called vasorefractive shock, vasopressor refractive shock. So in this case, in the case of vasorefractive shock, you have to add hydrocortisone. Now the role of hydrocortisone comes because the septic shock could be having relatively adrenal insufficiency. So we add hydrocortisone. Hydrocortisone dose is either you give 100 stat followed by 50 QID, or you add 200 microgram 200 mg per day as an infusion. The fourth vasoconstrictor you can add, that is angiotensin 2 or dobutamine. Angiotensin 2 is started at a dose of 20 nano microgram per kg per minute, and you can also start with dobutamine, although it is an inodilator if the patient is having cardiac dysfunction also, and you are able to maintain a MAP of 60, then you can add this dobutamine as well. So this is how you go. You start with noradrenaline. You are not able to maintain BP with noradrenaline even at the rate of 0.3 microgram per kg per minute. You as vasopressor as a fixed dose of 0.03 international unit per minute. Even with these two, you are, despite of adding this noradrenaline and vasopressin, you are not able to maintain MAP of 65, then you go add adrenaline. adrenaline you starts, and if you are not able to maintain so you have to start noradrenaline, or you're not able to maintain map of 65, you add hydrocortisone. You have started hydrocortisone, then also you are not able to maintain map, then you can add angiotensin 2 or dobutamine. So this is how you go for it. The minimum dose of noradrenaline and adrenaline is 0.05 microgram per kg per minute, and maximum dose you can go up to 1 microgram per kg per minute for ADR and adrenaline, that is, and for noradrenaline you can go up to 3 microgram per kg per minute. Thank you.